Uh, Good afternoon, everyone. So I think we're going to start the session. Thank you very much all for joining us. My name is Syed Irfan Kabir, and I'm a hepatobiliary surgeon at Shaukat Khanum. And this is a session dedicated to the specialty of HPB. It's a quite an exciting session. We've got a combination of surgeons, oncologists, and other scientists joining us as speakers. And this is going to be a very varied session with a little bit for everybody. So I'm going to start the session by introducing the chairs. The first would be Professor Farooq Afzal, who's the current Dean of Surgery at Lahore General Hospital. He's the principal of Services Hospital. He's been a pioneering surgeon, having trained in the US and then coming back to Pakistan and Lahore, and he set up a number of firsts in the country. So I would welcome him and ask him to please come join us as a chair. Thank you so very much. The second person I'm going to ask to come as a chair would be Professor Irfan Ahmed, who's a well-known surgeon in the HPB circles. He trained in Pakistan and then went over to the UK, where he was a professor of surgery at Gordon University in Glasgow, and he's got a distinction of holding two chairs in two universities, which is not very common. He is currently at the Pakistan Kidney Liver Institute and is pioneering minimally invasive approaches both in liver as well as robotic surgeries. And we'll be excited to see how that journey goes. And I'm sure he's going to bring a lot to Pakistan and for us and for our patients. So I'm going to ask Professor Irfan to come and join as a chair as well. Please, thank you. So, and the speakers we have is Mr. Michael Silva, who's a hepatobiliary consultant surgeon in Oxford University Hospitals in the UK. He has been a dean, sorry, he's been a lead for training there. He's a lecturer at the Worcester Hospital and has been instrumental in setting up the HPB services there. And he's a very good mentor, and he's been my teacher as well. So I would ask Mr. Michael Silva to come and give us his talk, and he's going to talk about how we can expand the curative intent surgeries for pancreatic cancer. Thank you.
Thank you, Irfan, and thank you for the invite to be here. It's an honor and a privilege to be here, and I'm delighted to be able to actually witness how good the services you offer here and the excellent work that you're doing is really commendable. So it's a real eye opener, and well done indeed. The topic I'll be covering today is based upon our approach to dealing with pancreatic cancer, the results of which are still abysmal when you compare to what's happened with other cancer treatments. We are lagging behind when it is environment where there is progress being made, especially if you look in comparison to where melanoma is today and where it was a few years ago, and compare that with where pancreatic surgeries and pancreatic cancer treatment outcomes are. We are so far behind. Even esophagogastric surgery and their outcomes have improved, albeit marginally compared to the others. And when you look at the incidence, overall there is about a 4.7% depending on where you look, incidence per 500,000. But that depends on how the capture is. And if you look at the most populous countries in the world, China and India, their incidences are far less when you compare it to a country like Japan or Germany, for example. And looking at what I could find on what is published data for Pakistan, you realize that the reported cancer deaths in comparison to what is in UK and the population differences are also starkly variable. And that's largely, I think, due to data capture and not due to how the disease behaves. But I think from what I've learned over the few days I've been here, the demographics and the tumor biology of cancer here seems to be slightly different to what we experience in the West. Our median age is 71 years when we treat a patient for pancreatic cancer, as compared to a much lower median age from what I understand here in the UK, in Pakistan. I'm going to talk largely based on these three streams that I've highlighted here. I'm going to give some insights into the debate of upfront chemotherapy versus upfront surgery for this disease, and look at how we in Oxford have expanded in a small subset of patients the resectability of pancreatic cancer, and then a really short glimpse of what basic science research we are doing to try and increase the curative intent. Now, why is it such a difficult disease to treat? And that is largely due to the beast we are dealing with. It is such a heterogeneous cancer. And if you look at the molecular phenotypes and the profiles, it is so complex that it's so difficult to even comprehend how you can get one treatment that addresses the whole problem. So there is a complexity in the disease that you're dealing with. And in addition to that, it results in a response within the tumor environment. For example, the fibrosis and the reaction that it causes in the stroma around it also uh, adds to the resistance to the chemoradiotherapy that is offered for this disease. And that is why, in addition to the fact that the presentation is always late in most patients, it is so difficult to treat. And we basically look at these four stages when we are confronted with a patient. We have a patient who's resectable from the get-go, or you have a patient who has borderline resectability where neoadjuvant chemotherapy plays a part. But if you look at that, more than 70% of patients are inoperable from the onset. And what basis do we talk about operability? The majority of the tumors occur in this region in the head, and if there is some involvement or even complete involvement of the portal SMV complex, we still consider that resectable. It is if it involves the artery or the celiac axis that we consider it locally advanced and not resectable from the onset. And that's because we know from data from those who have resected and reconstructed the artery that the outcomes are pretty poor. Whereas if you resect the vein and reconstruct, you can still achieve a degree of curative intent, and that is how we base our decisions. And this is just to highlight a patient who would be considered resectable. There is some abutment, so that's the portal vein. There is some abutment of the vein, which can be resected. The artery is well clear and therefore would be a resectable disease. Whereas in this case, this is a body of pancreas tumor. It is impinging on the vein, but it's also abutting the artery, and that is what we would call a borderline resectable tumor. And this obviously engulfs all the vessels and therefore would be considered encasement and therefore locally advanced and non-resectable at the onset. So what are the treatment options? We look at surgery and adjuvant chemotherapy afterwards for the resectable part, and for the borderline resectable, we go for neoadjuvant chemotherapy and then resection, whereas the others will get chemotherapy in the palliative setting. There is a small subset who can be converted to resectability after palliative chemotherapy in some instances, and I will show one of them who we have dealt with that way. Now, for decades, we've been offering them gemcitabine-based chemotherapy, and in the latter part of the last decade, we started using a combination therapy of FOLFIRINOX, which has shown better outcomes as compared to what was previously, where we had just uh, short of 30% 5-year survival in those with gemcitabine. We started seeing an improvement in outcomes with FOLFIRINOX. However, this combination treatment is a fairly toxic, potent chemotherapy dosage, and therefore a lot of patients didn't end up getting the whole complement of treatment, or would have had less than optimal treatment, or even non response to it. So with the better outcomes, the question started being asked, should all patients be getting upfront chemotherapy? And that is a practice that sometimes was adhered to in the US, although we never took it on in the UK and in Europe in a complete all comers get chemotherapy from the onset. And that is largely related to the fact that some patients didn't respond at all and some patients progressed while on chemotherapy. And in addition to that, it was toxic, and therefore some patients didn't complete the chemotherapy. So the argument that there is a better outcome because you weed out those who don't respond and therefore you should operate on those who respond was also something that we looked at. And as such, we started offering chemotherapy for patients who had vein involvement. And this changed our practice over the last 5 to 6 years. And therefore, if we saw on staging at MDT that there was abutment or involvement of the vein, we would send them straight on for chemotherapy rather than offer them resection from the onset and consider them resectable. And this is highlighted by our results. If you just look at a snapshot between 2016 and 2018, we resected more veins and considered them resectable from the onset versus a longer duration with far less vein resections that occurred in Oxford over the last 4 years. And then we started seeing emerging data from fairly well-designed randomized controlled trials where we could see that the upfront surgery patients were doing better than those who underwent chemotherapy. And that, although even this paper has some flaws within it and can be argued, that was largely due to less patients getting to surgery and the non-responders actually being not offered treatment and therefore losing that window of opportunity for treatment. In addition to that, there is another concept in pancreatic surgery, and that is fast track to surgery. And in those who are operable, using the doctrine that if you don't stent, you get less infection related complications and no stent related complications. More patients are treated that way, and therefore we went on to fast track, as well as now we reverted back to the practice of vein resection if needed. So this is the clearance one would get at a Whipple's procedure after the specimen comes out. That's a portal SMV. That's the common, that's the SMA, the supramesenteric artery, the aorta, and the IVC, and that's the divided pancreas with the duct there, and the celiac axis that is cleared. And that's what you would expect in a normal clearance after surgery. But often, if you get a tumor that's adherent to the vein and you peel it off the portal vein, you get this thickening that could be just a desmoplastic reaction, or you might end up with an R1 resection. And it's those patients that we consider vein resection. So what do you do when you're faced with a situation where you've got the portal vein, SMV, and this much of tumor adherence to the vein, which is depicted better in this diagram, where you will then have to resect that much of vein if you were to clear the tumor without R1. And these are your options. You could either take a side bite and just close the vein, but there is a high chance of narrowing and thrombosis. We use vein patches, but more often we use bovine, pericardial bovine patches that are freely available, or we do a complete resection of that segment and an end-to-end primary anastomosis, which is what we most commonly do. But if that resected part is too long, then we have to use a vein graft. or use a synthetic graft. And these were the options that we are faced with. And looking at the choices, which is better, we clearly can see from what is published, although the numbers are not that great, is that primary anastomosis is probably the best. And the use of interposition vein graft has similar results to primary anastomosis, whereas using anything synthetic results in a higher chance of thrombosis. And we published the UK experience of vein resections and the types of resections and the outcomes as a group, because the numbers then resulted in something plausible. And that clearly showed that the outcomes of vein resection are similar when it comes to the type we used. And we also, in another paper, showed that the oncological outcomes were also comparable. So therefore, vein resections are safe, and vein resections should be taken on when needed. So what do you do? How do you plan when you are faced with the situation where there is this amount of vein that needs to be resected? And this is not when you start trying to plan what to do. You need to be able to plan ahead and know what you want to do prior to getting to that situation, prior to having to scramble for what the options are. So in Oxford, as I think is the choice all over the place, primary resection and primary anastomosis is the choice. But there are instances where you have to consider graft, and that is when you're resecting more than 2 centimeters of vein, and sometimes even less than 2 centimeters if you have a patient who's not stented. Now you need to remember that this part of the vein, as opposed to that runs under the pancreas, this part is in the mesentery, and because it's in the mesentery, it has a very, very thin adventitia. So you cannot stitch this back and suture that and reconstruct it if there's any tension. It is so thin, it's wafer thin, that it cuts through, and you cannot do a safe anastomosis. So if you've not stented, you usually end up having a very friable vessel, and therefore you cannot reconstruct. And in that, it's far better to put a graft than to get into trouble and then be looking for a graft at that stage. So that is something to be aware of. And the other is sometimes, even if it's less than 1 centimeter, if you've got a patient who's really big with a BMI and a very bulky omentum, and the mesentery cannot be mobilized closer to the top end, again, you are at risk of having a tear, and therefore use a graft is how we decide. So that's how we decide when to use a graft. When not to even attempt is also really important to know. And if we are having a defect that measures more than about 4 centimeters, we will not resect the vein. And if you end up going into these jejunal tributaries, if you're taking that length of vein and you're now into the jejunal tributaries, then you'll end up with a graft that you have so many anastomosis to do down here, plus length makes it very likely to thrombose. So don't do what I ended up having to do in one case. This is nearly 8 centimeters of length. And this was an unplanned situation where we didn't even have a matching graft for luminal diameter, and ended up using a PTFE graft, and that's the portal vein and splenic vein, and 2 tributaries anastomosed here. Thankfully, this did not thrombose immediately, but it thrombosed about 8 weeks later. But by that time, the patient had developed collaterals and therefore survived and is still alive today, but again, not to get into. So when you see vein involvement, like in this case, patient stented, and you can see there's tumor, it is encroaching into the vein at the SMV portal vein confluence. You need to know that this is likely to need a vein resection, so you need to plan. And the other is that you can also predict that you might need to take an artery if the replaced right is going through the tumor. So we end up embolizing it pre-operation so that you can easily take the vessel. So what do? We do a Cuttle-Brass procedure instead of cauterization, so to expose the renal vein completely. And prior to getting into the tumor the resection of the tumor itself. We prepare this so that you can put a Satinsky at the renal hilum and have this vessel cleared and ready to be taken, so that if you need it, just before you take the tumor out, we will then take this graft. And always remember to put two stay sutures here, because in one case I hadn't put a stay and this slipped, and the artery, the vein ended up being difficult to control. And that's the principle of the anastomosis. We usually do the top end first and then the bottom end. Once you take a 2 centimeter graft, it just shrinks into this tiny little sliver of tissue, which obviously stretches to, and that's what it looks like at the end, with a nice another size match is also important, and that is why we choose the renal vein. The other advantage is that you don't have to get another specialty to harvest a graft if you're going for external jugular vein, for example. And this is an example of a patient that we've done this, and clearly inoperable from the onset, but exceedingly good results after chemotherapy, with the SUV on PET scan completely disappeared and CA 19-9 coming down to normal. So we explored and resected it off the artery, sent for frozen section. Frozen section was negative, and then we went on to resect and reconstruct, and the patient had a PT2N0 disease. About 4 years later, he's still alive, which is a really good outcome, but it doesn't happen often. So what happens to the renal vein, to the left kidney after the operation? And that is, uh, its outflow is taken up by the gonadals as well as the adrenal vein. And as you can see in this, clearly it's drained down into the pelvis through that and keeps it alive. And we looked at the outcomes of using of the veins in these patients, and find that other than for a mild degree of AKI on day 1 to 3 post-operation, there is no effect on the kidneys long term. So the results are good, and because it's an accessible graft, we will always take that on. Just a quick spin through what we also are doing with regards to precision treatment or matching treatment to patients. So in an ideal world, you'll study the tumor and give the appropriate agent, rather than give a all-comers type of treatment. And we also can clearly see that there are windows of opportunity. There is a, a delay in diagnosis most of the time, but at the time of treatment, we get tissue that can be then analyzed prior to the patient being fit enough to have chemotherapy. So matching the chemotherapy is something that we would like to do. And although there is a missed opportunity, there is something that we can do. So how do you understand how complex the tumor is? There are many methods. You can use it in cell culture, but that is really isolated and not representative of the real thing. You could try organoids, but then that is a microenvironment that is incomplete. You could use it in animal models. Again, it's difficult because it takes time, and you could tumor sequence, but it's expensive, and then you don't have treatment for every gene that you find that's different. So we thought of using avatars, and that is by taking fresh tumor, fixing it using a vibratome, and then creating avatars and perfusing that, we get a tumor environment that is more representative than in the laboratory form of isolated cell culture. And perfusing it keeps the micronutrient environment clear. And this is just to highlight how the opportunities can be used. This is a patient who had FOLFIRINOX, had side effects, didn't have the treatment, and then progressed as per scans. As you can see, he developed liver mets, had gemcitabine, and had an amazing outcome. And looking at in the window that we had and perfused the tissue, we could see that if the patient had been given gemcitabine, he would have had an excellent outcome. And so that could have been a matching of that. And I'm going to just rush through this because I'm in at time. So we are using that model to trial lots of other therapies and also radiosensitizing tumor so that they can be responsive. And the basic science work is done by these and not by myself. But these are our trainees who are now working within the group. Thank you.
Thank you very much. Thank you, Michael. We have one question, time for one question. Anybody is interested in asking a question? Yes, Samir.
Thank you. Excellent talk. Just one query about the patient where you used the synthetic graft. Could you have considered a spiral saphenous vein graft? Because that can give you a length of up to 8 centimeters.
That's a very good thought and a valid question. The problem was that we didn't plan that operation and ended up in that situation where we suddenly realized it was for benign disease. It was for a very large serous cystadenoma that was causing pressure effects. And we were happily taking it off the tributaries because we thought that the blood supply was safe, and suddenly realized that there was no portal vein. And in that situation, we didn't have time to go and take other grafts from anywhere else. So we just had to get out of jail, and that's not a situation to be in. So that was unplanned and definitely the wrong graft for that. But I think the patient got lucky.
All right. My question. I mean, any experience of using this peritoneum as a graft?
No, but I've heard instances where it's been used, and I think it's easily accessible. So if you think you want to use it, the problem with that is that it is thrombogenic, and I'm not too sure whether it's licensed to be used in that sort of situation as well, because of its thrombogenicity. Whereas using a prepared bovine patch is probably better, or using a vein graft.
All right, thank you.
Thank you very much, Mike. So let's move on to the next speaker. It's Fiek Froling joining us from University of Glasgow online, who's going to talk about oncologist perspective on evolution and future of pancreatic surgery.
Thank you to the organizers for inviting me to speak at your symposium. There, I'm sorry I could not join you in person. My name is Fieke Froling. I'm a medical oncologist at the University of Glasgow with an interest in therapeutic development for pancreatic cancer. And I am delighted to discuss with you today some work that's happening within the UK and globally in this field, working towards personalized treatment options for pancreatic cancer. As many of you know, patients with pancreatic cancer have a poor prognosis. Its incidence and mortality are rising globally. Here you see the statistics from the US, where you can see that pancreatic cancer has already overtaken breast cancer mortality and is soon also about to overtake colorectal cancer mortality, making it the second cause of cancer-related death. And this is due to multiple reasons. We've not made many advances, as you can see here in its relatively flat line, but at the same time, patients present late. Many of them are too sick to receive any cancer treatment, and a majority of patients have metastatic disease. However, in any study that we do, we always see a tail in the Kaplan-Meier curve. So for any novel treatment or any standard chemotherapy agent, we do see some patients who are actually responding. So I think we do see significant responses in a small subset of patients, but they're undefined subgroups, and we need to get better in identifying those patients up front. But then what treatment options do we currently have? And here I listed the randomized phase 3 trials that have been done for patients with advanced pancreatic cancer. And as you can see, the improvements have been relatively modest. we've seen improvements in the control arm, so maybe we got better in managing and delivering our chemotherapy. But over the last 10 years, I would say we predominantly focus with treatments of either FOLFIRINOX or gemcitabine and nab-paclitaxel, and this has not significantly changed. Within the UK, NALIRIFOX is not approved, and due to its similar survival statistics for all common populations and its increased toxicity and associated costs, I don't see it gaining major traction in the UK. In terms of other targeted treatment in the phase 3 setting, at the moment, the only study that's been done is for patients who carry germline BRCA alteration and had obtained good disease control following a period of platinum-based chemotherapy, where these patients were found to show a response to olaparib maintenance treatment. Then there's other treatments currently approved for small subset of patients in terms of their molecular profile, but traditionally this is for a small subgroup of patients representing less than 1%. Hopefully, this will change soon. As many of you know, there's different KRAS inhibitors on the horizon, and Revolution Medicine just announced their phase 3 trial of their KRAS inhibitor for patients carrying a KRAS mutation. But at the moment, we still hear, okay, what do we give to our patients? Is it FOLFIRINOX, Gem/Abraxane, or possibly NALIRIFOX? But as mentioned, the median survival of any of those regimens is less than a year. We have, however, learned a significant amount about those two different regimens, FOLFIRINOX or Gem/Abraxane, and obtain additional real-world data. And different studies have shown different results, where a large randomized phase 3 trials in an unselected patient population between those two regimens has not directly been performed. But here you see studies that show similar survival outcomes. Then you see studies which show FOLFIRINOX is superior. Others show that gemcitabine and Abraxane is superior. Some people may argue, given the design of the NALIRIFOX trial, which was Gem/Abraxane versus NALIRIFOX, that this shows FOLFIRINOX is better. However, I would say we need biomarkers for those different treatment regimens. And I would say the real-world data shows differently. And different biomarkers are being studied by different people. This is work done from the Canadians, where there is a main hypothesis that the molecular subtypes that we see in pancreatic cancer can predict response to first-line treatment. As you may know, lots of work has been done on subtyping pancreatic cancer, where the overall consensus is that there are, broadly speaking, 2 transcriptional subtypes, a relatively better classical subtype and a poor prognosis basal-like or squamous subtype. And here you can see that those subtypes are not only prognostic, but they may even have a predictive element in terms of response to first-line treatment. And you can see that patients with a classical subtype did better on FOLFIRINOX compared to Gem/Abraxane. And the basal-like patients actually did better on Gem/Abraxane. This is based on transcriptome analysis. Can we simplify that and use different markers? And this was again worked on by the Canadians, who think GATA6 may be a strong representative marker, where your GATA6 high patients are of the classical subtype and your GATA6 low patients of aggressive squamous or basal-like subtype. And again, in this work done by Grania O'Kane, it was shown that in their first-line metastatic setting, this GATA6 expression could predict response to your chemotherapy regimens in the first-line setting. This was then taken further in the next step in a randomized phase 2 trial that was run within North America. The PAS-1 trial, which randomized patients between either Gem/Abraxane or FOLFIRINOX. Primary endpoint was progression-free survival, and the study was not powered to such a degree to really answer the biomarker question. But it has multiple translational endpoints where multiple biopsies were taken for molecular profiling, organoid generation for pharmacotyping, and additional assays such as multiplex immunofluorescence or circulating tumor DNA, all with the aim to tease out, can we better predict responses to the first-line treatments currently available. So this work will come through over the next years, but the initial data was presented at ASCO this year. And you can see that in an all-comer population, there was a trend of progression-free survival that was better for the gemabraxane arm. However, with the notion that patients who carried a germline BRCA or BALB2 mutations were excluded from the study. So indicating that if you increase those known platinum responders to your all-comer population, your gemabraxane may have an inkling to be superior. But again, the statistics are not powerful enough, and I think we'll need more data. And the biomarker question will be key in this study. But overall, this just indicates the challenges we have in patients who have pancreatic cancer. Because at the present time, I don't think we've solved the question of what is the optimal systemic treatment. And that's right. So any disease setting, in an advanced setting or in the resectable earlier disease setting. What's the optimal treatment sequence? First line, second line, maintenance treatment, neoadjuvant chemotherapy, adjuvant treatment. What regimen does radiotherapy fit in here anywhere? It's again a localized treatment. Lots of questions just using the traditional modalities. But the key challenge in anything we do, whether it's from therapeutic development, is the rapid deterioration in performance status. Pancreatic cancer patients are sick. So all in all, to make improvements or learn better how to treat those patients, we need a better understanding of the molecular biology. And that includes not just the molecular biology of the epithelial component, but also about the tumor microenvironment, especially now also there's so many novel drugs coming through in terms of your bispecifics and your antibody drug conjugates. We need to get strong preclinical evidence, so there's a strong rationale to test our drugs, and then use smarter clinical trial design. Can we use synthetic control arms using the gemabraxane as a control arm for just as one of the examples? At the same time, I think we zoom in and focus a lot on the cancer, where we know the patients with a similar stage, similar tumor size can behave very differently. So there is patient or host diversity. And this goes from all different aspects. So I think we need to increase the diversity in our studies. We need to make sure our trials and data are actually representing the whole world. So I'll touch on some of this in the talk today, but overall it highlights that for a highly lethal but relatively rare cancer, we need to work together. It needs a well-coordinated solution. And with this in mind, Precision Panc was established within the UK, where the overall aim was to integrate the different pillars of therapeutic development, from your clinical trial to deep molecular characterization of your patient samples, to then studying of novel targets in well-characterized preclinical models. So you create your strong preclinical platform of evidence to be translated back into the clinic. So the study was initially funded by Cancer Research UK, and the first patient was recruited at the end of 2017. And central to the clinical trial aspects of the program is the Precision Panc Master Protocol, where the diagnostic pathway and the tissue pathway for molecular characterization has been integrated, where patients provide consent at the time of their diagnostic research biopsy, where they give consent for a potential additional research biopsy. If we then see that there is enough material for genomics, patients provide their consent for molecular profiling. If we then indeed see there's enough material, they are suitable for a Primus trial. So what's then performed in terms of molecular profiling? Patients get clinical genome, so that's targeted capture sequencing of about 300 genes, and it's integrated with a histopathology assessment to result in a final report that's shared with the treating clinicians. Then in addition, we perform transcriptome sequencing, and depending on the different studies, there's options to do a liquid biopsy for cell-free DNA, methylation, or potential other studies. And it also creates a platform to take additional biopsies if needed for additional molecular assays. So the study has been going now for 8 years, and it's developed into a self-sustainable platform with both the molecular profiling is evolved as well as the different trials which you see here at the bottom. There, we soon realized that we could just go use diagnostic surplus, and there was no need for an additional biopsy to do molecular profiling. Then during COVID, the sequencing machines, which were initially based at the university, were moved into the NHS to work towards an ISO-accredited assay. A national molecular tumor board was started, and now we also including other biomarkers of interest for specifically other novel agents that are coming through in a range of small multiplex panels to be incorporated. Here you see the different trials, and the main point to take away is that there are different investigator-initiated trials from different investigators all across the UK that have now a platform to recruit from different 35 sites across the UK. I'll mostly show you data about the Primus 001 trial today, which is the main driver of the platform. It's first-line metastatic trial of FOLFOX Abraxane versus Gemabraxane, again with the main biomarker question: if patients who have homologous recombination deficiency do better with platinum-containing regimen. But then in terms of patient recruitment, all in all, we see a very high upstream attrition, where we see only 85 of patients are ultimately registered for the master protocol, and even a lower proportion enter then a subsequent clinical trial. And the reason for this are different, but the key element is that many patients actually deteriorated in between the time that they had a diagnosis and then by the time they were seen in the oncology clinic for entering in the trials. And this is data we don't really see in any of the big trials that are reported. So then we just focus on the final aspect here. Anything that happens to any of the other patients, we don't really learn about or see anything reported about. So I think it highlights also the importance that we need trials that represent the real world. Then similarly, in terms of the sequencing of pancreatic cancer, here you see a traditionally H&E slide of pancreatic cancer, where only this is your epithelial compartment. So epithelial compartment is very low, and that's what we're interested in when we look at the genetic makeups of the cancer, our molecular profile, where there is a strong desmoplastic fibrotic tumor with a low immune cell infiltrate traditionally. So sequencing pancreatic cancer is tricky. And that's also what we see, where we see overall, there's still a 12% upstream sample fill, where 63 samples were insufficient. And this is relatively low. We have a pipeline optimized for low input DNA. And if we see a sample didn't work, we try it again. And that's something, for example, you won't easily see with your Foundation Medicine assays, where Foundation Medicine would just tell you, okay, no, not enough material, we cannot sequence this. And then even then, despite all those efforts, and we get a sequencing, we see that at the time of the analysis, we still see 6.4% sample fill, where we see indeed that the cellularity is low with a wide range. But then if we profile, this is the data of the first 380 patients, and all in all, it's not significantly different to what we already know about the molecular profile of pancreatic cancer. Heavily KRAS driven. And I think it's an exciting time now where we see increasing KRAS inhibitors coming on the horizon. And then you see TP53, CDKN2A, AMD, and SMAD4 as the main drivers. Another interesting target coming through is MTAP loss, which is often co-deleted with CDKN2A and B, which we haven't highlighted here, but that represents about 40 to 50% of the patients. So exciting times ahead for the KRAS inhibitors, but also this subgroup here, if your KRAS wild type. So all in all, though, it's still dominated by the 4 major drivers and then a long tail of different other alterations. But as mentioned, your KRAS wild type. If we don't see a KRAS mutation, first of all, you need to ask the question, is it a true KRAS wild type, or don't we pick it up because of low cellularity? And that's what we see here. We actually identified a KRAS mutation, but it was below the QC metrics because of its sequencing coverage. But then if you are a true KRAS wild type, we see there are actually multiple alterations that are highly actionable. This represents gene fusions, even though this was a DNA assay, so we may miss some assays. And for a pure fusion assay, you need an RNA-based assay. But patients with microsatellite instability, which we see in about 1% of patients who can then be treated with immunotherapy or your DNA damage repair or other alterations. So main message, KRAS wild type, go on the hunt for other drivers. Similarly, what we identified is around 6% of patients were found to have a pathogenic germline variant. And at the moment, we're still performing tumor normal sequencing. We're soon moving to tumor only sequencing. And again, this is a group which is highly actionable, predominantly for your BRCA1, ATM, POLB2, BRCA1, for which you have DNA damaging agents, MMR deficiency, and then importantly, it has implications for your family members. Then, as mentioned, we can do the transcriptome sequencing, where we use TempoSeq. And here you see the distribution of your classical in orange or your squamous basal-like, or you can do different subtyping approaches. But all in all, this is not hugely different to what we already know based on the studies done of resectable pancreatic cancer. We may see a bit more of the highly aggressive squamous or basal-like subtype in the metastatic setting. For example, here we also looked at your primary tumor and your metastasis. But this then allows a more integrated analysis. And in the era of the different KRAS inhibitors coming through, we also know that the different KRAS alleles that are mutated are having different biology. They're not the same. And we do see subtle differences where we may see slightly more KRAS G12D alterations in patients with metastatic pancreatic cancer and maybe more G12R in patients with resectable pancreatic cancer, where we know that your G12R patients tend to do potentially better. And then we can start to integrate it from a research perspective with the different subtypes. And this just indicates a different biology of the tumors that are driven by a different KRAS mutation. Where, for example, you see your squamous subtype has a lot more of your Q61H mutation. It's a mutation, again, which has shown to be associated with more aggressive pancreatic cancer biology. And again, we see differences in the primary tumor or in your metastatic sites. So this is just a short summary of the molecular profiling that we can do if patients have a good performance status and can be enrolled in clinical trial. But what do we do with this then, the rapid deterioration in the performance status, and how can we increase the diversity? And in the last minute, I'll touch on that relatively quickly because I think time is running out. But one aspect I'd like to highlight here is we focus a lot on the tumor, and overall we've learned a lot about tumor biology. But do we know about the host, about the patient, and how do we stage our patients? So I think there is a whole element of the interactions between the tumor and the host, and can we stop the deterioration of our patients? And this is one thing that we are investigating by different modalities. And one aspect we also know is that we see differences in the host based on ethnicity. And here you see the data from England, where we see that the British Black population tend to do worse compared to the Asian population. But then even globally, we see differences based on ethnicity or race. but overall the data remains limited. Similarly, we know that a big driver of the disparities or the differences in cancer outcome we see in the UK is driven by your social determinants of health. And I only moved to Scotland in 2020, and having trained in different places, it's actually quite striking the differences we see in Scotland, where it has the largest disparities of all of Western Europe and higher cancer incidence and a higher mortality compared to the rest of the UK. And indeed, what do we see then? How does this relate to what we see of this real world data and the attrition that I showed to you earlier? In terms of the tumor biology, we see that those patients who registered for the Precision Bank Master Protocol, but then were no longer fit for any clinical trial, or only received 1 month of treatment and then had to stop because of toxicity or rapid deterioration, they are more of the squamous subtype. We see that they are more systemically inflamed, using your Glasgow prognostic score, measuring CRP and albumin. If you have a raised CRP or low albumin, your patients do worse, and they are less likely to receive any treatment. Similarly, when we look at our West of Scotland cancer data, we see that patients of the most deprived areas are less likely to receive any form of treatment. So all of this, I think, highlights the needs that in any of the study, we include the different ethnic groups, we include the different patient populations, and we start to appreciate the differences that we also see within the host. But yet, we are predominantly reporting on Caucasian patients, or these are studies done in the US. And as you see here, we see a large underrepresentation of many of the trials done. And similarly, if you look at the big genomic consortia, the Cancer Genome Atlas, the TCGA or the ICGC, again, it's predominantly whites. But there's then emerging data that there are differences in biology based on ethnicity or race or your genomic ancestry. We can look at this genomically, but then also on your social determinants of health. But yet the data, all in all, remains limited. So with this in mind, we actually just started a large program to study this, to study the societal ancestry and molecular biology of cancer inequalities. Where initially of the Cancer Quant Challenge, we are focusing on patients of the African diaspora. But within the UK team, we're now aiming to expand this to the different populations. So I think it will be really interesting to look at potential differences we see in the population in Pakistan, for example, versus the UK population. But then as part of the program, we're going to integrate all the different aspects of tumor biology, where look at the social determinants of health, patient's exposure, which you can measure in the blood, how your environmental exposure contributes to the different cancer biology, molecular profiling, and your different immune phenotype. And also strong patient engagement. I won't go into a lot of detail, but this is the group involved. And as mentioned from Glasgow and from the team in the UK, we keep now working on different programs to expand this to different populations. So all in all, we need to focus on the different host biology. And there's different aspects we can do that. We can look still at the tumor microenvironment by using multiplex assays, but then also using your CT scans and doing, for example, body composition analysis, or looking at your circulating cell phenotype. So lots of work coming through in this particular aspect, and this program has just been started, but we're excited to take this forward and thereby consider not just the tumor, but also the host and develop studies that are more representative of the real world and the real patients that we see. So with that, I will conclude there. Overall, I think it is obvious that for pancreatic cancer, we need a well-coordinated approach to address all the different challenges. It's tricky to sequence pancreatic cancer, but it is possible. We see the attrition upstream, we need real-world data, and we need novel approaches to manage the rapid decline in performance status. So more post-tumor research and understand the diversity. So with that, I'd like to thank the Precision PANC data. So there's been an effort of all of the UK, where I'd say now the research biopsies are all taken in diagnostic procedures, and there's been a strong platform for therapeutic development. And then there's many people involved in all the work. So thank you very much, and I would welcome any questions.
Right, we're running a bit late, so we won't take any questions, but just one comment based on this talk. I was really pleased to hear about diversity and real world data. I believe we deal with a different pancreatic cancer in this country, and there's a lot of national faculty sitting here. The average age for pancreatic cancer, which Mike told us, was 71 years. My data shows that after working in two major cancer centers, that it was 48 years. So we see a much younger population here. I think genetically we are a different population than the West. So surgery will remain the same, but I think we need to collaborate with our potential partners. There are lots of people who are going to help out there to start sharing data from our country so that we can collaborate in those trials. Paula Gane, who led ASPEC 5 trial, was here in this room 2 years ago when we discussed this, and we thought we are going to share that data. But obviously we need to start working on that. So over to Irfan.
So PK, we've got Jamshed here. You probably know him from
Dr.
Glasgow.
For a lovely talk. So I have one question for you. So we know that in metastatic pancreatic cancer, there are two recommended treatment regime, modified FOLFIRINOX and Gem/Abraxane. So what is your preferred option in both of them, regardless if the patient is fit enough and having normal bilirubin level? Or should we do the basal-like and classic type differentiation?
Yeah, I think it's the main challenge we face when managing pancreatic cancer. My preferred option would be starting patients within a clinical trial. So if we have tissue for molecular profiling, we would enroll the patients in a trial. If patients is young and fit, I'll have the discussion towards FOLFIRINOX. But saying that, I strongly believe we need biomarkers for those different regimens, and that we have, that they're both good treatment options. I wouldn't say FOLFIRINOX is superior, but based on the data we currently have, I would still start fit patients on FOLFIRINOX. That's
So Feke,
the short answer.
Thank you very much for that. Just to kind of put the figures into numbers, we do on an average of between 80 to 120 pancreatic cancer resections per center, some a bit more, some a bit less. And your median age is around 40 here. And we're seeing young patients in their late 20s, mid 30s, and some as young as 24. So I think if that's something you wanted to look at in terms of collaboration and taking this forward, I think that might be the way forward here as well, because the numbers are huge and the biology is very different. And I think this doesn't. So when I came back from the UK, I was very surprised by the age group, because what you see here is just mind blowing.
Wow. Yeah. Thank you. And again, I'm so sorry I couldn't make it in person to join you there, but that's there's differences in tumor biology that are driving these. And what we, for example, see, younger patients are more KRAS wild type. That's what we see in the UK. But there's different populations, different aspects. So it will be. I would love to collaborate on this and take this discussion further. So yeah, that's striking to hear. Thanks.
We're gonna move up forward. So
thanks. And again, sorry I couldn't be there.
Maybe next time. Right. So next, I'm going to ask Professor Mohammad Rizwan, who from the Aga Khan University. He's a professor of surgery. He's the dean for surgical education, and he's been one of the early adopters of liver surgery in Pakistan when HPB didn't really exist here in that era. So he's going to talk to us about textbook outcomes in liver surgery and the possibilities and challenges that they have faced in gaining these.
Thank you very much, Irfan. Thank you to the organizers for inviting me here. My talk is more surgical, probably not as immersive as the last speaker. I'll mostly talk about what we do every day. And I want to take all of you, because most of the people here are surgeons and maybe a few others also, but we need to reflect back and look at the outcomes of whatever we do in our practice. And here I'm going to focus on the liver surgery as a model. So the bigger question that comes to mind, whatever procedure you do as a surgeon, how do we assess the outcomes and also quality after a given procedure? And there are a number of parameters which are used traditionally. For example, morbidity, the death after procedure, length of stay, a critical care stay, maybe blood loss, maybe readmissions, number of parameters, maybe a few others, and also sometimes oncological indicators, for example, resection. Margin of resection is considered quite important in terms of oncological procedures. So the question is that, do these parameters give you the idea of how our healthcare system is performing? Does the patient give a real idea of how the institution, how the person is performing in terms of a procedure? I'll take you through some of the examples to make you understand the question here. So most of these parameters are actually do not capture the multi-dimensional aspect of surgical care pathway. Mostly we have small sample size from different hospitals, low event rates, and all of them make this data quite maybe less precise than what is required. And it's also difficult to use single outcome variable to compare different institutions. Maybe some hospital might have a lesser hospital stay, maybe ERAS is active there, but maybe a different parameter has a higher rate. So does it really translate into a better patient outcome? So that is why the focus recently has been on a composite measure, which is supposed or suggested to be superior to individual outcome variables, which means that you combine all those variables to give one composite measure, and that will form the textbook outcome. I'll use some examples. So the quality of healthcare in general is defined as degree to which health services increase the likelihood of achieving the desired health outcomes, right? And the quality of care would be best represented by proportion of patients for whom all the desired health outcome achieved. So I listed a few in my previous slides. So if a person has achieved all of them, that is the textbook outcome, not that the hospital stay was shorter, but morbidity was higher, right? That is the basic concept here. So the textbook outcome would be combining all the desirable outcome into one measurable element. So if a patient meets all these desirable outcomes, a textbook outcome is achieved. And this apparently represents a more holistic approach to the quality assessment. This was first described, at least to my knowledge, in colon cancer. This is about 12 years old study, and they focus on desired outcome of care after colon cancer resections. I'll use this as an example to assess what outcomes they used. So outcome was registered at day 30, which means a month. And if a patient did not have any one of them, the patient was thought to have a textbook outcome. And look at these parameters. So no post-operative mortality within 30 days, a complete resection or not, no re-intervention required, no stoma, no adverse outcome, which are grade 2 or 3 classification, and hospital stay of 14 days or less. Now, if you look at all of them, they may be different for different institutions. For example, 14-day may be a longer stay here in our setup in some of the hospitals. But that is what they used. But they identified that all of them may be different based on number of case factors. For example, age, gender, BMI, comorbidities, ASS score, tumor stage, urgency of procedure. So many different factors are there which affect these outcomes. But whatever the underlying parameters are, if a patient has achieved all of them and none of them happened, this is considered a significantly better outcome as compared to having any one of them. And that is why it's called a textbook outcome. Then I looked at the literature, and if you look at the studies, so the first few years after the first one were relatively quiet, but now there's a huge data looking at the textbook outcomes. And I'll just, again, use some of the examples. I'm looking at the GI cancer. So now there is a study on textbook outcome after esophagectomy. Gastric cancer, systematic reviews. This is about rectal cancer, proctectomy for rectal cancer. This is about complex GI surgery for cancer. And also more complex procedure like cytoreductive surgeries for peritoneal surface malignancy. So this concept of textbook outcome has really, it seems it has really taken up in some parts of the world. Also for us, hepatobiliary pancreatic surgery is one of them. So when I looked at the literature, so almost all cancer types across specialties have had this type of data. And not just cancers, also emergency surgery, trauma, organ transplantation, the comparison across hospitals and across surgical approaches, all of them has been used to look at these outcomes. But what is this actually for a given procedure? That's the question, right? So does one size fit all? And I thought I should look at the liver surgery as a parameter for us because that's what I do in most of my situations. So questions. So what are the parameters to be included to achieve an ideal outcome? So which means what is really an ideal outcome in this given situation? Who's going to decide? Who's going to get an agreement? What are the confounders? For example, some of the confounders I mentioned in my previous slide. And how to address the case mix. Will the outcomes be realistic and applicable across the patients and the institutions because different institutions will have different resources, for example, right? So the process has been taken. There has been some way forward to answer those questions. And this is the first study I'm going to quote. This is again a few years old, mostly European data. They looked at the assessment of outcome and laparoscopy and open liver surgery, and they tried to develop some of those parameters required for liver surgery. So they did an international survey using Google Form and to formulate a consensus-based definition for textbook outcome in laparoscopic and open liver surgery. This was sent to all the members of EHPBA and HPBA, and 116 people responded, mostly from Europe. They initially identified 19 questions for each open and laparoscopic liver surgery. And if there is an agreement of more than 70%, this was considered as a part of their textbook outcome parameters. This is what they came up with for liver surgery. No intraoperative incidents, which is grade 2 and 3. I'll go into that. No grade B or C bile leak. No major complications, no readmissions, no in-hospital mortality, and a complete resection. So these were the parameters they came up with for liver surgery. So if a patient has achieved all of them, that is when this is a textbook outcome. And they looked at compared the open versus lab. The results were slightly better for the lab in their study. This is thousands of patients' data which they used here. A more rigorous process used again by some of the surgeons. This was an international experts Delphi consensus for textbook outcome in liver surgery. And they sent invitations to different people. And they had 44 people who collected for this consensus from all over Europe, America, Asia, different parts, different countries. And they went through different rounds of formulating the process or identifying the parameters to be used for liver surgery. And this is what they came up with. Again, 5 domains, 7 parameters. So intraoperative, no major intraoperative incidents, which is grade 2 and 3. I'll go into that. Absence of 90-day postoperative complication. They're looking at 90 days and no readmission because of these complications. Postoperative bile leak grade B or C, no liver failure, no or absence of in-hospital 90-day mortality, and then again, all R0 resections. These were the parameters they used from that Delphi consensus. So just to give you some idea, so based on those parameters, they actually have developed an online calculator, which is available, which can be used for any of our patients. And I use this in some of our data. So for intraoperative incidents, the grade 2 and grade 3 is defined by Oslo classification, which means a significantly higher blood loss or an organ injury, or for lab surgery conversion to open because of a complication, not because of the expertise. And grade 3 is even higher. And similarly, the international definitions for bile leak and post-op liver failure, which are already there. But they identified some limitations, even despite this process. They think that they had still fewer participants. Despite invitations, there was lack of gender diversity. There was not much input from other specialties. This is mostly surgeons here. And there was not much diversity in advanced technology. For example, all of them may not be involved in minimally invasive surgical procedures. And the question that they raised was that even, for example, for these parameters, which they used here, what is the weightage of each? All they are equal or they're different? For example, intraoperative complications way higher than maybe re-exploration or something like that. So are they all equal? So that's the question they raised. Okay. And also, more importantly, that those parameters may be variable, may have a different rate for different group of patients. For example, patients might be different. The tumors might be different, their size, number, extrahepatic disease. Treatment characteristics may be different. For example, what approach, any preoperative treatment, resources, patient volumes, etc. So all of this, even despite doing those parameters, requires some sort of adjustment or case matching. Okay. But then using those parameters, people have applied this concept, and there are many studies. I use a couple of them. This is, I think, a Dutch study, which is a population-based study. That is why I chose this, couple of years old. And they assessed at the outcome of liver surgery using those parameters. So this was, as I said, a population-based retrospective review over a period of 3 or 4 years, or maybe 2 years. They has a definition of TO, which is mostly those parameters, but slightly different. And they use multivariable logistic regression to adjust for case mix here. So they had about 2,300 patients across 23 hospitals. They were able to show that they achieved a textbook outcome in 80% of patients with liver mets, which were colorectal, 76% patients with other metastasis, 74% with HCC, and only 51% with biliary cancer. So you see, if the disease changes, despite being the same procedure, the outcome changes. And this is how so these are the parameters they used, and this is how the outcome has been different. Okay, then they looked at the various hospitals. For example, look at the left-hand side. So if you look at different hospital textbook outcome, it ranges from, let's say, 93% to 65%. Which means, is this hospital doing much better than this hospital? And then they use the adjustment methods. And when they put this hospital in funnel plot, most of the hospitals are actually falling within 95% of the confidence interval, which means although the number being different, outcome is more or less similar for the patient. Then just one more study to quote here. This is a systematic review, I think, published last year. This also has some US data, not all the European data. And they did a systematic review of all the studies published for the textbook outcome for liver surgery. And they started with, as usual for many systematic reviews, with 200 plus, but came out with 32 studies after different exclusion, which they used here. So their population was about 90,000 patients over a period of quite a few years, 20 plus 27 years. The US definition for each of these studies varied. Most of them used 4, 5, 6, or 7 parameters, but median of 5. And for them, the textbook outcome rate varied from 11% to 77%. Again, because of the huge diversity across hospitals, across institutions, and patients. And these were the factors which had an outcome on the textbook outcome. So then I thought maybe we should look at our own data. Does it fit our data also? So this is our data for the last few, I think about around 5 years or so. So you're about 200 plus patients. This is our median age. Some male higher proportion, 50%, 53% had at least one comorbid that led to higher ASA. 1/3 had underlying cirrhosis, and at least 1/3 had major resection, which means more than 3 segments. And these are the pathologies: HCC, biliary tumors, metastatic tumors, and benign. And most of our patients had single lesion. This was the mean size, which is about 6 centimeters. So when we looked at the outcome, and this will show you the essential challenge here. For example, look at anything. Let's say the Cleveland-Indo score in our patients was 82% had no major complication, but 18% had. Similarly, readmission. Bile leak, which is 89% had no bile leak, but 11% had. Liver failure, about 3%. Mortality, about 4%. But so these are the individual parameters, but you look at the overall score, our overall score is 76%, which means these problems are varying across the patients. If one patient had higher complication or readmission or bile leak, the overall score for this complication may be still less, but the outcome for the whole population goes down, right? And then we looked at our pathology, for example. And again, this is unadjusted data. We did not use any adjustments here. So our TOLS for HCC is lowest, 73% versus biliary tumor is 75%. Metastatic tumors, about 79, 80%, and benign pathology, 82%. Again, overall 76%, but variable across the diseases, right? So, and this is my last slide. So the challenge, so although if you think hypothetically, textbook outcome is an innovative concept. You look at from the patient's perspective, the patient would know that, okay, this is the best possible outcome I can have, which means you have no serious potential problems. But there are a number of issues here. First of all, what is an ideal or acceptable textbook outcome for an institution? Is there a number? Is it 80%? Is it 70%? Is it 90%? There's no number. Basically, you have to look at your own population. Maybe a number of institutions can have some comparison across each other. Similarly, is there a consensus on parameters that are being used? And there's already a concept of TOLS plus, which means there is a need to include the hospital stay as a parameter. So this is a discussion which is going on. And moving forward, what method do we use to compare textbook outcome for the case mix? As I said before, patients are different, tumors are different, hospital resources are different, preoperative treatment is different. So how do you adjust for that? So these are still the question and challenges, but I think looking at the data that I reviewed, I think this is an upcoming concept. Maybe the trainees should know, maybe the surgeon should know that just looking at the individual parameter is probably not the ideal way of assessing the outcome for our own population. We should look at all the parameters combined together to give the best possible outcome for the patient. So thank you very much. I'll stop here. 2 minutes earlier, if I may.
Thank you very much. Is there any question from Dr. Rizwan?
Thank you very much, Dr. Rizwan. It's been an excellent talk, and I think that is the future of quality control in HPB surgery, at least. There's a few things and which you touched upon as well, and I think one of the problems that we have is, and we looked at our data using the same parameters, what we find is your R1 rate, maybe for colorectal resection, might be high compared to your R1 rate for HCC or cholangio. And on paper, that might make you look bad, but the reality is actually that's good, because then that shows you're doing more parenchyma sparing surgeries, which tends to have a higher grade. So those are the things you kind of touched upon. My second question is, when it comes to comparison of organization, there is a tendency of people to then put up walls. So with this, that again, and I think this is a great thing to do, and I think we probably do need to do that as a country. But how would you propose we go about without people feeling that they're getting victimized or something along those lines?
So thank you very much, Irfan. So your first question is about the outcomes are variable depending on the disease. So I think my talk was mainly focused on the procedure. This is about the liver resection. But as I shown in some of my slides, if you want to look at the disease-specific procedure, then we have to look at the parameter for those, for example, colon cancer. So liver resection for colon cancer. It will not compare for HCC or for anything else. So we have to limit our data and the parameters used. And maybe need to develop parameters for liver resection for metastatic tumors, and then we can come up with an acceptable number or parameters to be used. So this was in general. This was in general about liver surgery, not about. And even despite that, you could see that the scores were different for different pathology, right? And R1 may be acceptable for example, colorectal cancer undergoing liver resection because you are sparing parenchyma, as you said, maybe longer. Longevity may be higher, but not probably for HCC or any other pathology, right? So that's how they're different. The other question you asked is about how do you compare the institutions, right? I think I don't have a solution. So what we can do here is I showed you one of the calculators, which is not with me, which is not with you, which is an international calculator. We can put our data there anonymously and look at our own numbers. But at the end, I think the solution is that we should be able to trust each other, right? That's how I look at it. So I should be able to, if there's a problem and I want to seek a solution, I should be able to come to you and have some conversation. This is the problem I'm facing. How do you resolve this together? Rather than hiding in a corner and saying, I don't want to tell Irfan about it. So I think we need to probably learn to talk to each other and trust each other. That's what I would think.
Yeah, thank you, Rizwan. I have a comment about it. So we were talking about the comparison of the institutions. So there's a professor from Harvard Business School who's in Indian origin, and he basically compared the cardiovascular, this cardiac bypass outcomes in India, at Pune, with same surgery done in United States. $6,000 cost in India and $100,000 cost in. So I think when we are comparing the institutions, this textbook outcomes, they must consider the cost which you are basically providing. So there's a concept called value-based healthcare, in which you're not only comparing the outcomes, best you are also comparing what penny you are basically spending on each of the patients. So I think in answer to this, I think the cost also should be included in textbook outcomes.
I would not, as I said before, there are a number of limitations of this concept also. Which institution, what resources do you have? Do you have really CUSA, for example, as liver surgery is concerned? Do you have ultrasound? Do you have laparoscope? Do you have high quality instruments? And all of that would add to the cost, but may also change the outcome for the patient in so many ways. For example, one of the studies I quoted, the outcome for laparoscopic resection was better than open in other studies, but it's a huge cost. So I could not disagree with you on this, that the cost remains a serious consideration in all of this. But as a concept, I think this is something to keep in mind. Yeah.
Understand the concept of value-based healthcare, because it's not only your outcomes, it's patient's experience that also matters at the same time. You go to the big hospitals, but the patient experience is bad. This is not a good thing for the institution. Thank you so much, Rizwan, for a wonderful talk. Thank you. So, well, the next talk is from UK. Dr. Alex Gordon-Weeks is going to from Oxford. He's going to talk about development of radiomics models. All right. He's going to talk about development of radiomic models for the prediction of oncological outcome in patients undergoing resection of colorectal liver metastasis. And it's a virtual talk.
Good afternoon, ladies and gentlemen, and many thanks for the opportunity to present at this fantastic conference, and sorry that I could not be there in person. Today, I'm going to present to you some work that we've been doing in my research group, looking at the role of CT-guided radiomics for predicting overall survival in patients undergoing potentially curative resection for colorectal liver metastasis. My name is Alex Gordon-Weeks, and I'm a consultant liver and pancreas surgeon working within the Nuffield Department of Surgical Sciences and Department for Hepatobiliary Surgery at the University of Oxford. And we perform this work in collaboration with a group of liver surgeons at the University of Liverpool. So colorectal metastasis is a major public health burden in the Western world. And we know that it is the main cause of death for cancer, for colorectal cancer patients. About 30 to 50% of colorectal cancer patients will ultimately get liver metastatic disease. And so it's important that we understand more about the etiology and the biology of this process. Half of those patients with metastatic disease are diagnosed at the time of their primary surgery, their primary colorectal cancer, and the other half metachronously. There has been a stepwise improvement in overall survivorship over the last 20 years for these patients, and we can see this demonstrated quite nicely in this paper published by Memorial Sloan Kettering just last year. We can see in the dark green curve, the most recent population of patients have demonstrated a significant improvement in overall survival. But despite this, we're still only at 40% 5-year survival for this patient cohort, and this is from one of the foremost cancer centers in the world. There are a number of reasons why we're still relatively poor at treating this disease. The first is delayed presentation and detection. Although screening protocols have been rolled out in the UK, they've still had relatively limited benefit in terms of detecting metastatic disease early and treating it. We have some novel biological agents. We're still targeting EGFR receptor pathway and VEGF, but we're still lacking, crucially, immunotherapeutics for most patients. These have become relevant for patients with microsatellite instability, but that only accounts for about 7% of patients with metastatic colorectal cancer. We've seen an advent of microwave ablation, radiofrequency ablation, and we use them commonly in our patients in combination with radical surgical options, and that has improved survivorship in a group of patients too. And then finally, from the surgical side, we've seen increased use of techniques to improve the functional liver remnant, and particularly techniques we use in Oxford and many other places throughout the UK, including ALPS and dual vein liver embolization, also called liver venous deprivation, where we attempt to rapidly increase the functional liver remnant by blocking off both the portal inflow and the hepatic venous outflow. So all of these features have come together to slowly improve survivorship, but still it's not as good as it could be. As well as poor survivorship, we also have a problem with prognostication in patients with colorectal liver metastasis. And there's a case in point. These are the survival curves from 600 patients undergoing liver resection in Aintree Hospital, Liverpool. And you can see the top two curves show the overall survival first, and then the disease-free survival for the entire cohort of 60 patients. And that pretty much matches what we saw from the Memorial Sloan Kettering data. And then the survival curves below in blue and red show the same overall surviving disease-free survival, but for the best and the worst 10% of patients within the overall cohort. And so we can see that the overall survival curves really don't demonstrate the heterogeneity in outcomes that we see in the disease process. And of course, we know that that's the case. There are some patients with liver metastasis who do very badly and some do very poorly. Some do very well, sorry. But what about the clinical factors deciphering and determining these issues? Well, here's the table of those top 10% and bottom 10% patients. And what's really interesting is that the key clinical factors that we're taught are useful for prognostication really show no significant difference. So if we look at the number of metastases, the diagnosis of synchronous primary disease, node positive primary, whether the patients had lung metastasis at presentation or bilobar liver metastasis, you would expect that in such divergent prognostic groups as shown in these curves, we'd see significant differences between these factors, but we really don't. And so we really struggle to prognosticate in this patient group, and that gives us challenges with regards to selecting the right treatments. There have been a number of different prognostic algorithms developed in the literature. One of the first was the Nordlinger series of over 1,000 patients, and they identified age, the presence of serosal invasion of the primary tumor, node positive primary tumor, large metastasis or large number of metastasis, and a small resection margin as being significant factors in their patient cohort that predicted poor outcome. Since then, we've had the Fong criteria, and more recently, a number of other studies in the UK. Merv Rees presented this prognostic algorithm that included carcinoembryonic antigen, as well as the presence of extrahepatic disease and large liver metastases. But one of the problems is that these prognostic systems work well within the centers in which they're developed and then don't perform so well externally. So they have poor generalizability across multiple centers. And by and large, none of them has been used routinely to select treatments for patients. And certainly in our unit, we don't have a specific prognostic scoring system that we use. We tend to favor patients without KRAS mutation and with small volume disease. But ultimately, if a patient has achieved chemotherapy stability over a period of 3 or 4 months, and they have sufficient functional liver remnant, then we would put them forward for surgical resection. So what are the features that might be useful in prognostication? Well, we've had some of the features already. We know that there are patient-specific factors, including the presence of comorbidities, and this can be defined better using things like performance status and ASA grades. But there are also a lot of tumor factors that we can consider. Mutational status, and we've already mentioned KRAS. Microsatellite instability is obviously important, and in patients in the UK who have microsatellite unstable metastatic colorectal cancer, they have the option of being treated with immunotherapy with exceedingly good results. And this has been such a game changer that we now rarely see patients with liver metastasis getting to surgery because they have such an impressive radiological response following treatment with immunotherapy, as long as they're microsatellite unstable. But as I mentioned previously, that only accounts for a very small proportion of patients. And we also have BRAF mutation, which is a poor prognostic factor. However, there are targeted therapeutics for BRAF mutant cancers, and these are demonstrating some efficacy in colorectal cancer. And then more specifically, looking at the tumor itself, we have something called the histological growth patterns. So tumors can be divided into either desmoplastic or replacement growth patterns. The desmoplastic ones have a rim of inflammatory tissue between the tumor and the background healthy liver, whereas the replacement tumors co-opt the liver vasculature and invade directly within the hepatocytes. And these two tumors have very, very different outcomes. The desmoplastic tumors account for about 20% of patients, and they do very favorably. You could get away with a potentially smaller resection margin, and they tend to respond favorably to chemotherapy, whereas the replacement growth pattern tumors, which account for the majority of liver metastasis that we see from colorectal cancer, do less well. However, one of the problems is that you don't have any information on growth pattern before carrying out your resection, and so it's only useful in the post-operative period, potentially for guiding adjuvant chemotherapy or particular surveillance pathways. Then we have other factors such as the sidedness of the primary tumor and potentially things like circulating DNA and clinicopathological features. But what about imaging data? And really, this is the crux of this presentation. Can we use more from the imaging that we do of patients? Most of our patients will have a PET scan, a liver MRI, and a CT with triple phase at the outset of their diagnosis. And our question really is, can we learn more and use more from the cross-sectional data to identify different groups of patients and therefore use prognostic scoring systems based on radiological images to guide therapy? So here we come to radiomics. Radiomics is a process by which we extract quantitative features that might be invisible to the naked eye from radiological images. And we do this by analyzing at pixel level the differences in patterning that different tumors display. So your MDT is probably much like ours. The radiologist identifies that the patient has colorectal liver metastasis. We look at the location of the metastasis and we plan a resection accordingly, as long as I mentioned before, there's enough functional liver remnant to make the operation safe. Radiomics goes a bit further than that. It identifies the tumor and it generates a number of parameters from the tumor based on the intensity of the pixels from the image and where they're positioned in space. So most simply, first order statistics will be looking at the average Hounsfield units across the tumor. So a cyst, for example, would have a very different average Hounsfield units than a tumor. However, within the tumor itself and in different patients' tumors, we find that there is a different average Hounsfield units and potentially a skewedness of the Hounsfield histogram between patients. Then we have morphological features. So in its simplest form, the shape of the tumor, its sphericity, how round it is, or whether it has an even or uneven border between the liver and the tumor. And perhaps if you can detect that border, then you can identify those two different growth patterns that we mentioned earlier. And finally, textural features. So textural features look at the average range of pixels across the image and tell whether they are heterogeneous or not. So a cyst, again, would be very homogeneous, whereas a cancer that perhaps displays areas of hypoxia, inflammation, or angiogenesis, or necrosis, perhaps in response to chemotherapy, would be very heterogeneous in its pixel intensity. And we can assign values to this based on statistics. Then you have a range of different filters that you can apply to all of these to generate further statistics and further imaging metrics. And perhaps using artificial intelligence and machine learning, we could then use different patterns of radiomics features to identify tumors of different mutational status, predict survival, determine the different growth patterns or the response to therapy. We could also perform radiomics on the background liver, perhaps detecting liver disease or the ability of a future liver remnant to live up to its volume. So these are all of the sort of potential uses of radiomics. And when combined with clinical features, they can be used also alongside biological features, proteomics, mass spec, or transcriptional features to build up a much more complex picture of the tumor than we currently use. The trouble is there are lots of radiomics features. So here are just a few of them. And these are, as I say, used to describe the patterning of the pixelated image that we see on a CT or an MRI scan. You could also use radiomics to generate knowledge from a PET scan as well. So with all of this knowledge, we decided we'd look at portal venous phase CT scans and develop a platform for generating radiomics features and using AI and machine learning to identify features that might best predict overall survival in a retrospective series of patients who have undergone colorectal liver metastasis resection. So in terms of our methodology, as I said, this is a retrospective archive study. So we pulled scans from patients identified within our databases at Aintree Hospital in Liverpool and Churchill Hospital in Oxford. The Oxford cohort consists only of patients who have undergone major hepatectomy because we had collected a lot of data from these patients from a previous project. So this is a standard definition of a greater than or equal to 3 vascular segments. Whereas the Liverpool cohort consisted of all comers. So even patients undergoing wedge resections for small tumors were included. A couple of inclusion-exclusion criteria. So we wanted resection, obviously, for biologically confirmed colorectal liver metastasis, and patients had to have positive colorectal histology at the outset. In terms of exclusion, patients who had undergone previous hepatectomy were excluded because we were worried that that might confound the survival curves. Obviously, patients without colorectal liver metastasis following their resection. If we couldn't identify a pre-treatment CT, obviously that's a no-go because we wanted CT scans before any chemotherapy had been given, with the view that chemotherapy is likely to change the radiomics features that we detect and skew our data. The problem with AI and machine learning algorithms is that they're sensitive to missing data. And so we excluded any patients who did not have a complete clinical prognostic score. And we used a number of different clinical features in our prognostic algorithms alongside the radiomics features. And then finally, patients who had inadequate image quality were also excluded. Just a bit more about image quality. This is defined, or poor quality images are defined as an inability to identify the liver metastasis, lack of portal venous series, or image slices that are outside of 1 to 5 millimeters. So the way the radiomics works is that if you have larger or much smaller sliced images, it will throw out some slightly different image features, and that could affect your data analysis. The make or model of scanner wasn't specified as an inclusion-exclusion criteria because we wanted to try and develop a model that might work for a broad range of different scan types. We used the LifeX software. So if anyone, and many of you might not know about this, but it's a really nice piece of software. It's available freely online, and you can download it and analyze images directly from it. It performs all of the radiomics analysis for you and has a range of different segmentation tools that enable you to draw around your tumor or region of interest, and then it will extract the radiomics features for you after some image processing and normalization steps. And all of the radiomics features that we extracted conform to something called the Image Biomarker Standard Initiative. So this is a process by which particular radiomics features are validated internationally. The primary outcomes that we were interested in are overall survival at 2 and 3 years, and these are both analysed as a binary outcome. And then as a secondary aim of the research, rather than just seeing whether radiomics could predict overall survival, we wanted to generate a prognostic model using a combination of the radiomics and clinical features. And we're going to show you some results of both of those analyses. So this is our study pipeline. There's a process of identifying the tumors. So that's a region of interest, or ROI segmentation. We segmented the images in 2D. You could also segment images in 3D. And we do have some software that we've developed that can segment the images automatically without us having to draw the regions of interest by hand. However, that software was developed for hepatocellular carcinoma. And we found that, interestingly, when we ran our colorectal liver mets cases through it, it failed to identify quite a lot of the lesions. So we had to resort to hand-drawn segmentations in 2 dimensions. We generally took the center point of each metastasis and extracted features. And we also extracted features from the entire background liver as well, with the idea that the liver serves as a niche for incoming cancer cells. And there may be some processes within patients' background liver that increase the chance of metastatic recurrence. And so generating radiomics features from the background liver might be interesting. As previously mentioned, we extract radiomics features, and there are a whole bunch of different features that we've mentioned before. We then have a complex process of narrowing down the features. So we start with several hundred features, and that's quite unmanageable when we have a relatively small patient cohort, and we'll show the numbers of patients that we included in the analysis later. But we wanted to pare down those features. So there's a whole process of reducing the number of features that we utilize for the final models, and I'll show you that in a moment. We then apply some machine learning algorithms that we won't talk in too much detail about because they get a little bit confusing. And then we have a process of validating our models with a test and training cohort, and also generating out survival curves using a number of different techniques. So this is the selection criteria. We identified 950 patients for inclusion. We had quite a lot of patients who had to be excluded, the majority because of missing clinical information. So we had 6 clinical parameters that we wanted to include, and it was not infrequent to find that we couldn't identify them within our database. And then there are some patients excluded because of inadequate CT quality. And that led to 289 patients from the Liverpool cohort and 110 patients from the Oxford cohort. And we ended up segmenting just over 900 colorectal liver metastases and generating radiomics features for each of them. So this is the patient demographics from the Oxford and the Liverpool cohort. The patients within the Liverpool cohort are on average slightly older. And that might be something to do with the demographics. Liverpool is in a very different part of the country to Oxford. And it may also be because we selected all comers from Liverpool rather than just looking at major resections, which is what we did from our Oxford cohort. But most of the other features were reasonably well balanced between them. However, as described, the types of operation we look at between the two cohorts is quite different. As a result, some of the outcomes like the intraoperative blood loss and the length of hospital stay are also quite different. And then finally, it's worth noting that the overall survival for our patient cohorts is quite different too. So the Oxford cohort have a significantly longer overall survival than the Liverpool cohort. Again, there may be a number of factors underlying that. The Oxford cohort are patients who have been highly selected out after a period of neoadjuvant chemotherapy and presumably have relatively good biology, whereas Liverpool cohorts are, as I mentioned before, all comers. And the other issue to consider is that the average life expectancy of patients in Liverpool is about 5 years less than patients in Oxford because the demographics of the two populations are quite different. So the first step was to generate our regions of interest, to segment the tumors and to perform some pre-processing. As I mentioned before, we selected features from the tumor, but also the background liver. And we performed spatial resampling, which is really just adjusting the definition and the quality of the images so that they're standardized across all of the scales that we looked at. And then we performed something called intensity discretization, which is a process of reducing the number of pixels that we analyze within each image. So we make it simpler. The first process is to filter down the radiomics features. So the heat map on the left shows the total number of radiomics and clinical features that we started with. And what we notice is that quite a lot of the features are not adding additional information. So some of the features are what's called collinear. So they basically don't tell us anything that some of the other features are not already telling us. And when we extract and remove features that are not giving any extra information, we end up with this far more limited set of radiomics features. The clinical features that we include here are on the left. You can see, I'm sorry, the text is quite small, but they included the age of the patient, the number of metastases, whether the diagnosis was synchronous to the primary tumor, whether the patient had a left or right-sided cancer, whether there was nodal disease in the primary tumor, the degree of dissemination, so that describes whether there were lung metastases present at diagnosis, and finally, whether there were bilobar or unilobar liver metastasis. So those are the clinical features that we include alongside all of the radiomics features that you can see here. So just a note on the feature selection. If you imagine a set of radiomics features and their ability to predict survival, we have a bunch of relevant features in the center of our radiomics features, and then some highly relevant or optimal features. And the process that we next pursued to narrow down further the number of features that we include in our final models is called LASSO, or minimum redundancy, maximum relevancy. So we try and pare the features down to include only features that are supporting our outcome of interest, but making sure that they remain relevant. And there are some statistical processes for doing that. For those interested in that, this is the formula for that process. And this is just a diagram of how we reduce the number of features. So we ended up with about 7 or 8 radiomics features by the end of this process, as well as all the clinical features that we included. And we can see here in the curve on the right, there's quite a significant drop-off on the ability of each feature to predict a reasonable area under the curve with regards to prognostication as we filter out more features. So a whole bunch of different ways to reduce the number of features before we apply various machine learning models, which, as I say, I won't go into in too much detail, but we have access to a whole host of different machine learning algorithms that start with relatively simple processes such as k-nearest neighbor, where we simply assign patients to different prognostic groups based on similarity of their radiomics features, to far more complicated machine learning models, including gradient boosted trees, which are relatively complex and not necessary for this talk. So these are our results presented as ROC curves. So we can see this is the ability of the different features that we're interested in to predict mortality at 3 years. So on the left, we have the clinical features alone, and the different colored curves show the different machine learning models that we used for our prediction. So we generate a score just with the clinical features alone with an area under the curve of almost just over 70%, which is actually pretty good. An AUC of over 70 is considered to be clinically useful. But when we look at the radiomics features alone, they're already performing better. And a combination of radiomics and clinical features gave us an AUC of 84% for predicting mortality at 3 years, which is a pretty useful result from a clinical perspective. And this is, again, mortality at 2 years, showing a similar trend where the strongest predictability is where we combine radiomics and clinical features, and we achieve an AUC of 85%. So pretty good, and certainly something that we feel is worth pursuing, particularly when you consider that we generated the radiomics features from only a single slice of a CT scan. We're interested in combining MRI radiomics and PET radiomics to further bolster this result, and I suspect that will increase the prognostication of our models even further. Well, what about the features themselves? So here are in red are the features from the liver, and in green are the features from the liver metastasis. And what's really interesting is that actually quite a lot of features from the liver perform really well, suggesting to us that there's certainly something or some role in using radiomics to identify features within the background liver that might contribute to future metastatic dissemination and recurrent disease. If we look solely at the features from the tumor, most of them are looking at the heterogeneity of pixel intensity. So that will describe features such as the coarseness or the granularity of the tumor, perhaps suggesting that a heterogeneity in biological processes within the tumor is driving a poor prognosis. And we know that that matches with biological analysis of tumors as well. So we next wanted to develop a prognostic model that we could use and actually understand the differences in survival when we applied this prognostic model to groups of patients. So again, we have a feature selection process, which is based primarily on univariate Cox regression. And then we impute multiple Cox regressions using a multivariate analysis to generate a predictive score. And finally, we apply that to a survival analysis, grouping patients into high-risk and low-risk groups based on the performance of the score. And here is the analysis of that data, split first into a training cohort and then a validation cohort. So here we split the patients into 25 and 75% split. And what we find is that we can generate, using the clinical and radiomics features, we can generate risk categorization score. So in the survival curve on the left, you can see the low-risk patients had a median survival of 53 months, whereas the high-risk patients had a median survival much lower at 32 months. So again, you can use the radiomics process to apply a risk categorization and to score people based on their risk of recurrent disease and ultimately death. And it performs reasonably well in the validation cohort on the right, showing that the model is pretty robust. When we look using multivariate Cox regression at the features that are most predictive of overall survival in patients who have undergone liver metastasis, the radiomics risk score that we generated and applied to the previous survival curves is by far and away the most useful predictor when compared to any of the clinical parameters alone. So this data is just showing radiomics risk score alone versus any of the classic clinical predictors that we find are useful for identifying patients who might do poorly. And so again, this is just a validation that radiomics is useful for identifying patients at risk of a poor outcome following liver resection. And that's just highlighted here. So some comments on what we've presented here today. We've managed to validate a radiomics risk score using really quite heterogeneous data across two slightly, very different demographic groups. So that demonstrates some generalizability of our model. The feature reduction process was really important for reducing overfitting. So as an example, for each radiomics feature that you factor into your model, you need at least 10 outcomes of interest. So that would be 10 mortalities. So if we were to include 200 features, we'd need at least 2,000 patients to enter our model. So by reducing the number of parameters that we use, we've managed to reduce statistical error, and we believe that improves the validation of our model. However, this is a retrospective study. The differences between centers could be seen as a disadvantage, and we only analyzed radiomics from a two-dimensional segmentation of the tumors. The manual segmentation is laborious, and it's not really applicable to clinical practice. And we're currently working on algorithms that can automatically identify and segment the tumors from cross-sectional images. And also, I guess you could say it's a relatively small data set. We probably need thousands of patients to really truly validate these models. And I would also argue that we need to use both MRI and FDG PET imaging in addition to our portal phase CT scans to generate radiomics scores. And that's something that we're working on as we're developing a pan-UK image database that can feed into some of our next projects. So the future directions for us to identify and establish links between radiomics and core biological features within the tumor. So we've got a suggestion that radiomics is identifying patients that are at risk of poor outcome following liver resection. But what might that actually be telling us about the biology? And so we have of particular interest, wanting to understand the ability of radiomics to predict the different histological growth patterns that I mentioned to you. So here's an image of the pathological sections that we take from patients with liver metastases and some of the other work that we do. And you can see these two patterns very clearly. So top left is the desmoplastic growth pattern with this rim of inflammatory stromal tissue. And then next to it, the replacement pattern, where you can see that the cancer cells in the bottom right here just co-opt the liver in the top left. And when we look at those using complex immunohistochemistry, we find that the immune infiltrates in these two different tumors are really vastly different. So we can see here in yellow, lots of T cells infiltrating around the desmoplastic tumor. It may be that that T cell response is what drives a better outcome. So when you look at how different these are on an H&E, it's tantalizing that we might also be able to pick up those differences through radiomics applied to cross-sectional imaging. And this is really just a kind of view of what that possibility might hold. So the green are patients with desmoplastic tumors. They have almost 75% 5-year survival. And the red is patients with a replacement tumor and KRAS mutation who really do very poorly. So being able to pick up these growth patterns using non-invasive imaging would be really, really helpful. That colorectal liver metastasis. Clearly, it's not stable.
Volume.
External cohorts. So if anyone is interested in collaborating, we'd be more than happy to discuss that in more detail. The normal liver radiomics feature is really interesting. It suggests that you can identify features in the background liver that predict overall survival. And that is presumably because there are as yet unidentified biological features that promote the seed soil hypothesis and perhaps act as a pre-metastatic niche. So I'm going to finish there, and I wanted to thank you all for listening. I also wanted to thank one of our academic clinical fellows, Arid Mian. He's a surgeon in training, and he's done a lot of the AI and machine learning work for the presentation that we saw today. So many thanks for listening, and I'm going to end the presentation there.
Thank you very much for that. I'm going to feed back to Alex that you overran by 14 minutes. So, but that was an interesting talk. Any questions? No. Right. So I'll hand over to the chair so for their closing comments. And
I think thank you very much for this session. Just a general comment, and I think we have touched on this comment before, that we deal with different disease pathology in our country. When I came to from UK to Pakistan, I was of the belief that we are missing colorectal liver metastases, but I hardly saw any. In my 18 months in Shaukat Khanum, I saw about 4 of them. And in my last 1 year in PKLI, I've seen only 2. So the number of colorectal liver metastasis is very limited. We see a different disease biology, younger patient, and I think that's where we need to think about producing our own in-house research to look into these questions and come up with proper treatment protocol for our own patient. Cost is a major issue, and we have touched on that before, because, for example, a pancreatic cancer patient, if we are passing them through neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy, we are tripling the cost of their treatment. And with 50% of population below poverty line, I think that's something which we need to look at. Our healthcare system is struggling. We've spent less than 1% of our GDP on healthcare, and our population cannot afford these treatments. So just a comment, and I think something we need to look at in a bigger context locally and come out with local solution for our problems, and collaborate with our colleagues overseas to look into protocols which they have applied in their population, but use our data to come up with the right answers.
Yeah, thank you very much. I think I learned a lot from this session. They were both pancreas and liver were covered. And what the message I basically got from these talks is that we are going more towards precision medicine, and cancers are like getting more defined even at molecular basis. And even the diagnostic steps like radiomics, maybe we are coming to a time like hepatocellular, maybe radiomics are going to take away the need for biopsies and other stuff like that. So it's a huge revolution coming on with the help of this AI and all of those youngsters sitting at the back. I think you have a lot of opportunities for this research and going into adopting these fields. Thank you very much for the invitation. Thank you so much.
Thank you. So we're just going to end the session, and just one last comment. I think it's interesting to see that we are going back by 360 degrees, where we went from pushing more chemotherapy in pancreatic cancer, and now we're kind of going back to where we think we probably should be operating more, and unless the immunos come and then they tell us not to do the same thing again. But anyway, thank you very much for everyone. Sorry we overran by 20 minutes, but we have lunch, so we've got a break time now. Thank you so very much.